Hi, my name is Raven Hill, and today I'm going to be presenting you a study I did alongside Dr. Neumann and Amber Armstrong, and this is the feasibility trial of the facial affect recognition intervention and empathy module through teletherapy for individuals with a traumatic brain injury and their care partners. We had three main objectives. The first objective was to determine the feasibility of integrated intervention with facial affect recognition and empathy in the traumatic brain injury population via Zoom. And we called this intervention iCare. Secondly, we wanted to assess outcomes of interest, which included affect recognition, empathy ability, interpersonal behavior, and relationship between the participant with a traumatic brain injury and the care partner. Lastly, we sought to evaluate satisfaction of the intervention. So discussing the significance of how this intervention came about, there has been a lot of research of affect recognition deficits, which have been suggested to be up to 39% of the traumatic brain injury population. And affect recognition is defined as the ability to recognize emotion in self and others, especially through facial features and nonverbal body cues. And affect recognition is actually a precursor for empathy and the ability to empathize with others, which leads us to empathy deficits. And research has suggested that it could be up to 70% in the traumatic brain injury population. And empathy is defined as considering another person's perspective and having an appropriate emotional response to another person's feelings. So the integration of both of these really crucial concepts led to our conceptualization of the outcomes of interest. So starting with our demographics, both the TBI group and the care partner group had an average age of 39. The TBI group had a 50-50 split in sex, while the care partner group had 75% identify as male and 25% identify as female. In the traumatic brain injury group, 75% identified as white, while 25% identified as Hispanic or Latinx or of Spanish origin, while the care partner group all identified as white. For the TBI group only, we measured Tbi severity, where 25% had a mild to moderate traumatic brain injury, and 75% had a severe traumatic brain injury. In the care partner group, we asked them what their relationship was to the participant. 50% said spouse, 25% said partner or significant other, and then the other 25% said friend. So going into the inclusion criteria for our study, specifically for the TBI participant, they had to have a complicated, mild to severe traumatic brain injury. At time of enrollment, they needed to be 1 or more years post-injury, and they needed to have a willingly care partner for participation. The inclusion criteria specifically for the care partner was that they needed to have a close relationship with the participant. And then the inclusion criteria for both groups was that they needed to be 18 years old or older. The person with a traumatic brain injury and or the care partner must express that the person with the TBI has difficulty not recognizing others' emotions, and that this intervention may improve those skills and help their relationship. Additionally, both groups needed computer access and to speak fluent English. So now looking at the exclusion criteria, any of the following was means for the participant to be excluded from our study, which included premorbid neurological disorder, suicidal ideation, major psychiatric disorder, degenerative neurological condition, inability to follow directions, prosopagnosia, visual neglect, and visual, hearing, or communication impairments. So looking at the timeline of our study, when we first screened and recruited 14 participants, we ultimately had 2 screen failures and 4 participants who declined, which left us with 8 participants who were eligible and had consented at that point. Then the clinician administered the pre-assessments to both the care partner and the participant with the TBI. One participant ended up withdrawing during the FAR module, which is something I will discuss in a little bit. And then starting with the FAR module, this was session 1 through 7, which included identifying emotion, emotional event discussion, mimicry of emotion, feature similarity, and advanced emotional processing. Then session 8 through 12 was within the empathy module, which included the TFB triangle, perspective taking, empathic response, and 11 and 12 were listening skills. Finally, the clinician administered the post-assessments to, again, both the care partner and the participant with the TBI, and our final sample was 7. So broadly, talking about I-CARE, the I-CARE stands for Intervention to Change Affect Recognition and Empathy. And this intervention is a 2-part module, which included the FAR module and the empathy module. It was delivered remotely through Zoom telehealth. There were 12 total number of sessions, and the average session length was about 60 minutes. So looking into the FAR module, this was lesson 1 through 7, and was presented through an iPad app while the Zoom delivery was happening as well. This included identification of emotion, so the participant would see a face and try to identify the emotion that the person was feeling. Additionally, emotion mimicry was a part of these sessions where the participant had to mimic the emotion. Emotional event discussion included the participant discussing an emotional event related to a specific emotion. Additionally, identification of feature similarity for emotion was a part of the lessons where the participant were given different faces of the same emotion and were asked to find similar features of that emotion. Finally, advanced emotional processing asked the participant to take one of the emotional events from the previous emotional event discussion and discuss more about the physiological characteristics of that event or situation, and to go more into the interaction that they had with the other person and about their feelings. So here's an example of the identification of emotion part of each lesson within the FAR module. Part 2 is the empathy module, and this included sessions 8 through 12. This was presented via PowerPoint through the Zoom remote delivery. Session 8 was about the TFB, or thoughts, feelings, behavior triangle. Session 9 was about perspective taking. And this session, the care partner was encouraged to come alongside their partner, otherwise known as a participant with a traumatic brain injury. But it was optional. Session 10 was empathic response, and session 11 and 12 were about listening skills, of which the care partner was required to join. In each of the sessions, there were informational slides, exercises, and role play. So here's an example of an informational slide from session 10, where it just lays out just direct information about empathy and a TBI. This slide shows a role play example where we instruct the care partner and the participant to use the skills that they have used and learned about in previous sessions and apply that as a role play interaction with their care partner. So for our outcome measures, we sought out to target different aspects, which were affect recognition, interpersonal behavior, empathy, and relationship features between the participant and their care partner. Each measure was administered pre and post intervention. Starting with affect recognition, we use the DAMVA 2AF and the ACS SPFAN measures to measure facial affect recognition of the participant with the TBI only. In the following measures, both the participant and the care partner completed each assessment. For interpersonal behavior, we looked at the interpersonal behavior subscale of the SASNOS measure to look at behaviors or symptoms of neurobehavioral dysfunction in interpersonal interactions. We targeted empathy and used the GICE to identify a change, if any, in empathic behaviors in the participant, as well as the BAFQE to measure empathy-related behaviors in the participant. For our final outcome, we looked at different aspects of the relationship between the care partner and the participant. We used the RQS for each party to rate the quality of their relationship and used the URCS to measure the level of closeness between each other. Lastly, we looked at the GICR to measure the degree of change and overall quality of relationship between the participant and the care partner. So just looking at our feasibility outcomes, the most common problem that this intervention had was some minor Zoom or internet connectivity problems. Most of the time, both of these things were related. For example, the Zoom video chat would either lag or freeze in visual and audio output, which is usually an internet connectivity issue. However, this problem was easily resolved through reconnection of internet or switch to audio chat to continue the intervention. We did have one withdrawal, as I mentioned earlier. This withdrawal was due to the participant feeling uncomfortable with the facial mimicking portion of the study. There were no adverse events in this feasibility trial. And overall, there was high satisfaction in many areas of the intervention, 95% being very satisfied with the intervention, 95% saw this intervention being relevant to their needs, and 75% liked the remote delivery, with one person, which accounted for 25%, strongly disagreed. And obviously, this individual did not really enjoy the remote delivery aspect. This person was overall averse to meeting via Zoom compared to meeting in person, which he requested many times. However, a majority of the participants were satisfied with the remote delivery of the intervention, which helped reinforce the feasibility of the study. Here are some qualitative outcomes, specifically from the participant with the TBI. When we asked them, what did you like most about the therapy? These are some things that they said, which was really reinforcing and awesome to hear. Additionally, we also asked the same question to the care partners, and they gave some good feedback as well. So as you can see here, the affect recognition measure, which compiled both the DANVA measure and the ACS measure, significantly improved all participants' ability to recognize different emotions from multiple faces with differing features related to that emotion. For the interpersonal behavior measure, the SAS-NOS-IB was used to look at improvement of interpersonal behavior in the participant, as well as how the care partner viewed the interpersonal behaviors of the participant. On the left, we see that almost all participants improved from pre to post testing on this measure, except 2903, which seemed to decline on this interpersonal behavior measure. Additionally, it seems like the care partner of 2903 also showed a decrease in interpersonal behavior of 2903. Interestingly enough, 2903 had significant improvement on the BAFQ empathy measure, while 2903's care partner felt a decrease in the participants' empathic tendencies. Aside from 2903's care partner, looks like the majority of the care partners notice a significant increase in their partner's empathy compared to the participants themselves. We can see that most prominently for 2907, who we saw an increase on the BAFQ-E, which actually suggests a lesser empathic ability, but their care partner noticed a moderate improvement in empathy. For the RQS, or Relationship Quality Survey, we asked participants to rate their relationship quality pre-treatment and following the intervention and the post-assessment. Every TBI participant noticed an improvement in the quality of their relationship. Looking at the care partner data to the right, we see that half of the scores improved post-treatment, while the other half did not change. However, it was interesting to notice that all of the score were relatively high from the start, with a maximum score of 10 being the best quality. And as you can see, for the global impression of change, or GIC measure, for both empathy ability and relationship quality, most participants, including the care partner, had moderate improvement or better in those areas of interest. In conclusion, the outcomes from the 4 participants and their care partners were somewhat mixed with regards to impact on empathy, interpersonal behaviors, and relationship quality. These broad mixed results could suggest that the intervention may work well for some and not for others. We might also consider that the content within these lessons may take a while to make meaningful changes for the participants with their care partners. The measures themselves may not be sensitive enough to pick up on the changes for the targeted outcomes. However, the Global Impression of Change, or GIC measures, did suggest that both the participant and the care partner noticed improvements in empathy ability and relationship quality. Thus, the change on this measure may be more informative than the other empathy and relationship quality measures. In terms of results between the participant and their care partner, there was mixed levels of perceived changes in the post-assessment. This could be due to the participant's self-awareness of improvements that may not be explicit to their care partner. Another possibility may be due to minimal interaction between the participant and care partner. Overall, there are many different possible reasons for why we saw mixed results in the data. Although some of the findings were in the direction we expected and hoped for, and for the most part, participants were highly satisfied with the intervention, which is exciting to hear. This pilot study allowed us to demonstrate the feasibility of delivering this intervention remotely and get constructive feedback from participants for future improvements of the intervention. This crucial feedback will now influence the further evaluation and improvements to the intervention in order to conduct a more rigorous study with a larger sample and longer-term follow-up that will ultimately help us learn about the potential efficacy of the intervention. So this intervention fully encapsulates the advancement in evidence-based practice as a feasibility trial in improving affect recognition and building empathic skill sets for those who have experienced a traumatic brain injury alongside their care partner. Motion recognition and empathic ability are not easily identifiable deficits that clinicians can pinpoint in the TBI clinical population. Considering how hidden these abilities may be, it can then be difficult for clinicians to treat or address these deficits. To date, there is no published set of guidelines that help clinicians identify and treat these deficits for those who have experienced a TBI. This evidence-based intervention sets the stage in addressing these problems within TBI medicine and rehabilitation. Although this is only the beginning of the intervention, this study has presented intriguing and exciting data in hopes to continuing evidence-based practices for both clinicians and individuals who have experienced a TBI. By integrating the peer-reviewed FAR and empathy interventions together that was administered through Zoom Health, this intervention has successfully determined that eye care has the potential to ultimately help those who have difficulties recognizing emotions and engaging in empathic interactions with their loved ones. And here are my references. Thank you.